You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtina.com. On this episode of the Dr. Tina Show, I have a special treat for you guys. Ladies. I have been getting asked this for a long time. Back in 2020, I did a presentation for a company, and it was all about why women need testosterone too. And I've gotten so much feedback from that. It was a presentation for another company, though. I've never actually done one for my own audience. And I have recently updated my slide deck. And so for this episode, there's actually a slideshow. If you're listening to my podcast on a podcast player, just follow along. But if you want the actual whole presentation with slides, you're going to want to head over to YouTube. My YouTube channel is at Dr. Tina, and you can find many episodes of my podcast there in video format, as well as extras coming soon. So I want to get folks over to YouTube. I want to have a more interactive experience. So for this episode, we're doing a slideshow. All right, so I've got my slide deck pulled up here, and we're going to follow along. So back in 2020, like I said, I was asked to do a presentation for a company about how testosterone was necessary for women. And it's a very underappreciated subject. It's under talked about. It's even amongst hormonal experts, it's not often talked about. And I found over the years since then, with the myriad of messages I've received, that folks are having a really hard time finding doctors to prescribe to them. Women, folks, females with uteruses and breast tissue, women who were born biological women needing to get testosterone replacement therapy for various health issues, most notably pain, are finding it difficult, which is surprising to me when it's being handed out like candy to children. So on that note, what we normally think about with low T is usually men, right? Of course, it's the primary hormone in men. And we think about it being predominantly a male issue only. We think about it being an issue with erectile dysfunction or problems down there. We think about it with muscle loss, lack of gains in the gym, loss of stamina, potbelly, difficulty healing. That's usually where I saw it show up in my practice. I did a whole podcast episode about this last week. You guys can check out. And it's for the men, because this is actually Men's Health Month here in the month of June. So I did an episode for you guys. Ladies, go get your men to listen to that. But it's a big deal. And when men would come into my clinic to get regenerative injection therapies, they weren't healing well and they weren't responding well. We would need to pull out some testosterone usually. Of course, we tested them to make sure that they were candidates and it was safe, but it generally is very safe. Lesser considered issues with low testosterone would be type 2 diabetes. This is in men. Cardiovascular disease or heart disease, osteoporosis, depression, apathy, memory issues. They're not feeling themselves. Mood swings. That's a big one. Mood swings is a big one. If your dude's laying on the couch after work and not responding to you, and then when he does respond to you, he barks at you, and he's not normally like that, I'm gonna go with low T. Joint pain, and then sarcopenia, which is muscle loss. But women need testosterone too, and it is often considered only a male hormone. There's a book that you can check out called Testosterone Therapy in Women, Myths and Misconceptions. It's a great book. It was written in 2013 by Glazer. Her name is Glazer, last name. Abandoning myths, misconceptions, and unfounded concerns about testosterone and testosterone therapy in women will enable physicians to provide evidence-based recommendations and appropriate therapy. But the reality of testosterone therapy for women is that testosterone deficiency is not even recognized as an official diagnostic code. There's no diagnostic code for low T in women. So in men, it's hypogonadism because it's their gonads that's secreting testosterone. But in women, there's not even an official diagnosis. Hypoactive sexual desire disorder is defined in men, but not women, meaning women not desiring sex or low libido is clearly defined in men, but it's not even acknowledged in women. So when we talk about women's rights and healthcare, this is a huge one. Both of these issues are huge ones. 1 in 10 premenopausal women in the US suffer from hypoactive sexual desire disorder. And that's for a myriad of reasons. Often it's actually a side effect of SSRI medications or other things, but it's real. And women are not being even acknowledged, even premenopausal women. These are the women of childbearing age. Not to mention all the other symptoms and impacts of low T, which we'll cover here today. And it's not just libido, right? It's not just low libido. While women are barely recognized as having a libido in the first place or having libido issues in the first place, doctors certainly aren't looking at other symptoms of low T on the regular. I know I wasn't. And I actually feel pretty guilty about that. I think I missed this in a lot of women before I started using it and treating with it. So testosterone for women, T therapy for women remains controversial, and it is often considered the lifestyle therapy or vanity therapy. Right now, I have been talking about RFK on my social media because the guy is ripped. RFK Jr., if you haven't seen him, I've got to go over to my Instagram, check it out. I've got a picture of him up there with no shirt on. Funny story. I showed my dad. I said, look, he's 69 years old. Look at this guy. And my dad said, does your husband know that you have a picture of a shirtless man on your phone? And I thought that was so funny. But yes, Dad, I have a picture of a shirtless man on my phone. RFK is a smoke show, and good for him. He's clearly lifting weights, but he looks to me as a professional, my opinion is that he's probably on some testosterone therapy, and good for him, as he should be. Check out last week's episode so you understand why I think that. Common low testosterone symptoms in women. So there's sexual, disinterest in sex, negative body image, avoiding intimacy, inability to orgasm. That's a huge one, ladies. It's a huge one. You literally start to lose feeling in your vagina and your G-spot. And it sucks. So I've lived with this personally. I've had low T. I use testosterone replacement therapy on myself. I cycle it, and it's really critical for me. And I'll share more about that later. Low self-esteem, loss of identity, ultimately depression. It's just a general feeling of apathy and dumpiness. It's just mentally you feel dumpy, physically you feel dumpy. And I personally was going through cycles of intense injury in the gym, and I just kept getting hurt and I couldn't heal, and I couldn't get my strength gains up. And then there's systemic issues, right? There's fatigue, insomnia, migraines, belly fat, weight gain, decreased stamina, loss of memory, and so on. And then there's more symptoms of low testosterone. The skin, you lose tone and integrity in the skin. You get droopy and saggy. You start looking old. Your breasts start sagging. You get cellulite. Cellulite might be a low T symptom for women. And I think that's very interesting because we combat it in all kinds of crazy ways, but really it might just be a hormonal issue. As for mood goes, loss of zest for life, feeling like something is wrong, but you just can't put your finger on it. Anxiety, depression, inability to organize your thoughts. So you start to get that menopausal brain or that perimenopausal brain, which is real, Loss of motivation, loss of joy for living, loss of sense of well-being, loss of joy for living, i.e., having some really negative thoughts. And I've been there as well, and it sucks. So it might not be that you're losing your mind or that you're losing your brain function from perimenopause or menopause. You might be low testosterone. And I'll talk in a bit about why women will become more prone to low testosterone as they age. Body and immune symptoms. Autoimmune disease, this is huge. Please take note of this. This is huge. Autoimmune disease. If you have autoimmune disease, I highly encourage you to find somebody and get on some BHRT, get on some hormone replacement therapy, whatever you need. Testosterone and progesterone are protective against autoimmune disease. So get on it. Dry eyes, pain is huge. This is where I started noticing it in my practice and paying attention. Arthritis, joint degeneration, osteoporosis, lack of strength, and loss of balance. If you go back and listen to prior episodes, I talk about how osteoporosis is actually diabetes of the bones and osteoarthritis is diabetes of the joints, but diabetes and blood sugar dysregulation really should be on this list as well. It's a huge one for men, and I believe it to be a big one for women as well. Loss of balance though, guys, right? Women get old and break hips. So they're losing muscle, they're losing bone integrity, they're losing balance, they're losing brain cognition. Sounds like a problem to me. Sounds like a hip fracture waiting to happen. And hip fractures are the kiss of death. And that whole list, right? It sounds a lot like getting old, doesn't it? Right? It's just, this is old age. Sarcopenia, which is loss of muscle mass, osteoporosis, memory issues, and depression. These are all diagnosed. These are all diagnoses, and they all have drugs. There's nearly a drug for every single one of these symptoms. And yet I want you to consider that maybe it's low testosterone. Women have 3 times more testosterone than estrogen. Did you know that? I didn't know that until I started looking into this. Women have 3 times more testosterone than estrogen. So on this slide, you can see the pink line represents testosterone and you can see the blue line represents estrogen. And you can see how it really peaks here. Your testosterone really peaks for women from the age of, it starts going up in your teenage years. Around 18 years of age, it's probably, going up towards its highest, really peaking out in your mid 20s and then starting to come down in your 30s. And then obviously the decline becomes significant between your mid 30s and your mid 40s. This is why I'm so adamant that we start lifting weights. I'm going to talk about that later, but this graph came right out of the book, Testosterone Therapy in Women, the one I mentioned earlier on in the episode, and you can check it out in there. So this is a big, big deal, you guys. With this drop in testosterone comes a huge drop in muscle mass. This is why we strength train. And it's not always clear cut. There's physiologic dosing is an art in and of itself. Find somebody you can work with who will not only consider dosing you, but find someone who is knowledgeable in dosing and find someone who will get you in that physiologic spot, because we're not trying to turn you into a 25-year-old woman, and we're not trying to, we don't want you having the T levels of an 80-year-old woman. You need adequate levels. There's the difference between adequate levels and frank deficiency. And in the middle is this physiologic dosing idea. 1 in 10 premenopausal women present with low libido. This is rarely considered worth treating. It's not even acknowledged, like I mentioned. In men, libido and erectile dysfunction is often a late symptom. If you go back and listen to last week's episode, you'll hear me talk about that. Still, no FDA-approved androgen therapies for women, shockingly. Why prolong the misery, especially if there is pain? A lot of musculoskeletal pain shows up when testosterone is low. One of the first symptoms I noticed and that I noticed in my patients was the sensation of being cold and achy. And while that is a classic low thyroid symptom, a lot of our hormones start to plummet out together all at once. Good times. But cold and achy is often a symptom. And the first time I took testosterone, I immediately got warm. I got a sensation of warmth throughout my body. It was the dead of winter. I was bone cold and in so much pain. And if you know what I'm talking about, it's the kind of cold where your bones are frozen and you can't get warm and it hurts so bad. And you end up crawling up against your husband or your partner, begging them to cuddle you because you're so cold it hurts, right? And my husband, bless his heart, he normally complies. But if he's really tired and he's sleeping, he's like, leave me alone, woman. And I'm over there trying to get into any nook and cranny I can against his body because he's always so warm and so vital. And I'm sitting there freezing to the point of pain. This is where sauna, not going to lie, sauna is hands down my favorite therapy for the cold and achy situation. But, if you can't get your testosterone on board, but testosterone is really a big winner here. Women more than men will report being cold and achy. I've noticed in my practice, they can't get warm. Everything hurts. They feel like they're dying. Winter is especially hard to endure this. And the diagnosis often in a doctor's office is fibromyalgia, osteoarthritis, hypothyroid, myalgia, which is muscle pain, and it might just be low testosterone. And I've said it before with the episode I did a few back on thyroid. Go back and listen to that one. Please get yourself up. And I did one on menopause. I've done a couple on menopause and hormones. I want you to bone up on all the episodes so you have an idea of what I'm talking about here, because this whole picture goes together. But I really want you to consider, in any woman over 40 following a massive bout of stress or trauma, I want you to consider low testosterone. Yes, we would obviously consider adrenal glands here. And yes, we would definitely consider thyroid in anyone over 40 years old, but testosterone's a big one. So let's go back to the low testosterone and pain. Chronic pain patients often have low serum testosterone levels. Opioids also decrease testosterone. This is the scam that is pain management in this country. They pump people up on opioids. They basically make them sign a waiver. Go back and listen to my Orthopedic Medicine is a Scam series. There's 4 parts. They make them sign a waiver that they will basically agree to become an opioid addict. And then they're on opioids for the rest of their life. That's their solution. Isn't that lovely? That's the best they've got, which is crazy because my whole practice was dealing with pain. And I can't believe that was it. That was their answer. And pain is so prevalent. 1 in 5 to 1 in 7 patients present to any doctor's office for pain. So pain is real, not just acute, but chronic. So opioids, they get put on opioids, and guess what? It decreases your testosterone. How bad does that suck when you take opioids after a surgery or an injury, right? Imagine that. You need your androgens, which are your testosterone is your androgens. You need your androgens to heal because it's anabolic, but yet you're taking opioids, which is dumping out your testosterone. And opioids upregulate microglial cells in the brain to drive pain. I've done a couple episodes on pain. So go back and listen to those too, if this is interesting to you. Pain depletes hormones such as cortisol and testosterone via hyperarousal of the HPA axis. So a couple studies, just if you don't believe me, but low testosterone and pain, this was from 2015, a novel use for testosterone to treat central sensitization of chronic pain and fibromyalgia patients. Go back and listen to my pain episodes. We'll link them in the show notes. I talk all about central sensitization and what that is. It's a wind-up phenomenon in your central nervous system. And then there's another one that was from 2016, hypogonadism. This is in men. Hypogonadism and the risk of rheumatic autoimmune disease. So remember, I mentioned autoimmune disease. Rheumatic autoimmune disease is like rheumatoid arthritis, really devastating, damaging type of arthritis that's immune-driven, autoimmune-driven. So if you have autoimmune disease and you have pain, I seriously want you to find somebody who is willing to work with you and look at your testosterone levels, man or woman. Here's another one. Hypogonadal men with psoriasis benefit from long-term testosterone replacement therapy, a series of 15 case reports. This was really interesting. This is from 2016 as well. Psoriasis is a skin condition, but the link between psoriasis and psoriatic arthritis is super high. Like if you have psoriasis, you've got like an 80% chance that you will develop psoriatic arthritis at some point. And from the research I've done, psoriatic arthritis is more painful than rheumatoid arthritis, which I once thought was the most painful orthopedic condition you could possibly have, but it's not. Psoriatic arthritis is. And if you think of all the people you know with psoriasis, which is an autoimmune condition, and you consider that a huge percentage of them are going to end up with psoriatic arthritis, you can imagine the kind of pain they're dealing with. And this is rarely addressed or acknowledged by the medical system. Rarely does somebody actually get appropriately diagnosed because lab markers can lead to a lot of false negatives. And so this gets missed. And as somebody who lives with psoriatic arthritis, I can tell you it is crippling. It is crippling pain. And so when folks go off on me on social media, which happens a lot, I think it's because I'm a truth teller and they don't like it. You couldn't possibly understand Dr. Tina. And I'm like, au contraire. Try living in my body for a day. Try spending 24 hours in my body and see what pain feels like to me, because it is real and pain is subjective. It is not my job as a physician who specializes in pain to judge somebody else's level of pain. So I never do. And no two people in pain can have a comparison because some people's nervous systems are wound up hard and other people's aren't. And when it's immune driven and you've got central sensitization and you've got this autoimmune component, which is causing joint degeneration, joint fusion, all kinds of muckety. It can be really miserable. And so I feel for a lot of folks. And unfortunately, the best way to diagnose psoriatic arthritis is through signs and symptoms and history. And that's why it takes decades often to diagnose it, because there'll be glimmers. There'll be a one-off instance. There'll be a one-off symptom that happens. And it's weird. Like sausage digit is one, not to go on a bender about this, but this is important. Sausage digit, where just one digit, like one finger or one toe will blow up out of nowhere. The pain is not often bilateral, it's unilateral, and it shifts sides, it moves. SI joints are a big one. The spine is a big one. The big joints like the hips and shoulders, and it'll just jump sides. So one day, so for me, I had 10 years of horrific pain in one hip and one SI joint, and then actually 20 years to be, if you add in the SI joint. And then one day it just shut down, turned off, hardly any more pain, almost zero. And it just moved within a day. It moved over to the left side and it started its whole fun adventure on that side. And it's still going, and it was almost worse than the right side. So I say all this to share with you because these things are going missed. And testosterone has been shown to be beneficial in psoriasis and psoriatic arthritis. Interestingly, estrogen levels tend to be abnormally high. So folks will have higher levels, and this is looking at men. The only studies I could find were in men. So men would have higher than normal estrogen levels, and they don't know if it's the chicken or the egg, or if the immune system's driving the high estrogen, or if the high estrogen is a response to try to dampen the immune system. They don't really know, but they end up with low testosterone because estrogen and testosterone recycle into each other. And so they end up with low testosterone and higher estrogen and a lot of pain and a lot of skin issues. And so testosterone therapy has been shown to be helpful here. That was my rant. Hope you liked it. Here's another study from 2020, December 2020. Testosterone protects against the development of widespread muscle pain in mice. I don't really know how they could accurately measure pain in mice without asking them, but they had their gizmos and they found that this was widespread muscle pain, right? So that would be more of a fibromyalgia type picture, and testosterone was protective. As for joint health, testosterone makes healthier synovial fluid. So the fluid inside the joint becomes more fluid and less viscous. Again, go back and listen to my many episodes on the topic of joint health and pain. Testosterone impacts regeneration capabilities because it's anabolic. We need anabolic things. This is why I would often work with male patients, particularly to get their testosterone levels up so that we could make sure that they were in an anabolic healing state before I delivered regenerative injection therapies to them, because those were only as good as their ability to heal was. It is secreted by the chondrocytes. Isn't that wacky? Chondrocytes are your cartilage cells inside your joint. They secrete testosterone. So we need it. Apparently, we need it in the joint, and it improves osteoporosis. So these chondrogenic progenitor cells, CPCs, these are androgen receptors in the chondrocytes, and testosterone influences the expression of 3 receptor genes as well as the chondrogenic potential of the CPCs by regulating gene expression and impacting types 1 and 2 collagen, which is really, really different. You can see the study is quoted below, a 2010 study, sex differences of chondrogenic progenitor cells in late stages of osteoarthritis. Really interesting study if you guys are into orthopedic medicine, those of you practitioners out there who follow the show. And here is another table. This is a really interesting read too. Testosterone replacement, essential in pain management. This is from Practical Pain Management, Volume 14, Issue 4. This is called Criticism of, I'm looking at a chart. You can join me on YouTube and subscribe to my YouTube channel, and you can see it too. Criticism of study on possible relationship between testosterone and cardiovascular events. So what is this? There was some data that came out years back saying that testosterone was unsafe and that it caused cardiovascular disease in men. Testosterone replacement therapy was dangerous. And it was a poorly done study. I'm going to go through this a little bit here on some of the high points. They also didn't track estrogens in these patients. And so if you've got a pot-bellied guy, listen to the episode from last week. I talk all about the aromatase enzyme and how it turns testosterone into estrogen and how those high levels of estrogens are what cause the cardiovascular events. And these were not tracked when they were looking at these TRT patients in this study. So all subjects already had heart disease and entered the study at the time of coronary angiography. So the patient base itself in the study was flawed. They already had heart disease. This was a retrospective study of 8,709 patients who were followed for only a short time, 1 to 3 years. Cardiovascular events actually were lower in the testosterone group than the non, compared to the group not receiving it. Contrary to the raw event numbers, a complex statistical system of variable exclusions allowed the authors to adjust the raw data and draw opposite conclusions. So the data was flawed and interpreted flawed. The definition of testosterone treatment was a single prescription in a 1 to 3 year period. So they weren't even on a consistent regimen of dosing and tracked and made sure that their levels were correct. And the mean testosterone serum level achieved was super low, not even enough to really give these guys relief with the TRT. So whatever you've heard in the past about testosterone being dangerous for men, it's garbage. And I'm going to show you a study that came out this month, June 2023, at the end of this presentation. It's a slippery slope, right? So you get hypothalamic pituitary axis hits. What would hit that system? Chronic stress, some kind of major illness, acute or chronic, COVID, right? Anything that whomps you. And you guys have heard me say this before on the show. I really firmly believe that a lot of the quote unquote long COVID symptoms we're seeing are really just manifestations of prior conditions that people, men and women, were rocking, and then COVID sent them over the edge. So it really hammers the HPA axis. It was ironic that I did the original version of this talk in early 2020 before COVID had stormed its way in. I think it was January of 2020, because I have seen so many women pushed into menopause, pushed over the edge into hypothyroidism, pushed over the edge into severe adrenal fatigue. And they're being called long COVID patients, or their hair is falling out, or whatever the symptoms may be. And really, it's just their hormones got shook and their HPA axis got hammered. And coming back from that's hard without support and finding a practitioner who can help you. So in most cases. So please, if you're feeling like you've never been the same since, right? That's a very common theme patients would come into my office with in chronic pain. They were fine until something happened and they've never been the same since. And that was usually a viral infection. I've talked about that in past episodes. So this leads to this HPA axis hit leads to a deficiency of hormones, all the hormones, or any and all perhaps. And then eventually you end up with frank signs and symptoms. And so that can happen. It can take years. My adrenals were hammered after I gave birth. I was 25 years old. I gave birth to my daughter and I came out of it in the most severe adrenal fatigue. I dropped into severe hypothyroidism. Nobody acknowledged it. It was just baby weight, right? That's what everyone called it. Nobody would help me. And looking back on photos, I'm almost angry with my mentor for not acknowledging what was wrong with me and helping me. He's now dead, so I can't say anything to him. Bless his heart. I love him. But man, I was so hypothyroid and my adrenals were so shot. And then I started, years went on. And when my daughter was probably around 3 or 4 years old, on up till 8 years old, I started getting chronic pneumonia. And it really came down to severe adrenal fatigue. And once I got that, I remember my friend helping me with that in school and giving me some adrenal support supplements. I remember going back to her at graduation and just telling her, like, you saved my life, quite frankly. So it could be something as simple as that, all the way on up to a variety of other hormones, progesterones, estrogens, testosterones. I would assume to consider that any woman over 40 who presents with pain, particularly of the lumbopelvic region, lumbar, pelvis, lower back, hip or knee regions, hips especially if it's a non-traumatic onset, meaning they didn't have a physical trauma, they didn't fall down, there wasn't a big major event that hurt them. Maybe the event was traumatic in that it was a physical hit, like I said, like COVID or a viral infection, or even a divorce, you guys, something that will just hammer your ability to adapt to stress, can start this whole downward spiral because your adrenal glands secrete testosterone. So you need your adrenal glands functional. Otherwise you can't secrete testosterone as you age. And it really sucks. It really sucks as you age and walk into perimenopause. I would argue that much of perimenopause misery is actually HPA axis dysfunction first and foremost. And these folks need adrenal support. And go back and listen to the episode I did on thyroid because I talk about my hierarchy there. Don't wait until their joints are severe. I would see them in my clinic. Their joints would be in such a severe state of degeneration that it was very challenging to get them back. And usually they were in frank signs and symptoms. That's what this SSXS stands for on the slide here, signs and symptoms. And then there's that peri to postmenopausal phase, which I am a proud member of, rolling on in. Your testosterone dips, your progesterone dips, your estrogen dips, and it leads to a whole lot of misery. So these dips may happen at various times for various reasons. However, improving testosterone levels may improve the symptoms of low progesterone and low estrogen. I am a huge fan of using progesterone and testosterone first before estrogen. I did an episode on this. I talked about why just recently. Go check it out. I have found estrogen to be more challenging to dose. I know that other doctors might disagree with that and feel really comfortable prescribing it. I find testosterone to be very safe, and I find progesterone to be really safe. In fact, most states sell progesterone over the counter, so don't go playing with it without some guidance because you can overdo it, and then you end up with symptoms of feeling just as rotten as low progesterone. But progesterone can make the estrogen you have work better, and testosterone will actually turn into estrogen. Like I said, they recycle into each other. So that can be very helpful. There's no conclusive guidelines for women. There's no conclusive guidelines for healthy levels of testosterone for women. I often get asked this question by my colleagues because they'll hear through the grapevine that I've done this presentation and they'll say, oh, Dr. Tina knows. I don't know. I dosed people according to pain resolution on everything. That is how I did every hormone. And now I will tell you what else I did, because as a prudent physician, of course, I would test and I would make sure that I was not overdosing them. But there is no great set dosage or serum level that I'm going for. I want pain resolution without frank symptoms of overdosing, right? So in women, that would be like excessive chin hair, gonadal hypertrophy in the genital area, lowering of the voice. I mean, obviously you see some of these women that are bodybuilders that are on testosterone and they start looking very much like they're on testosterone, right? We're not going for that look. What we're looking for is pain resolution. And so I will dose them up because they might be severely deficient. I have to titrate them up. I need to titrate their levels up until they hit pain resolution. And then I test and I look and see, okay, what does that look like on paper? That's the best number for them. Is that in a safe range? Monitor closely, proceed. That's the safe way to do this, right? And any good doctor worth their salt will know how to do this. According to Kathy Maupin, The Secret Female Hormone, the book, The Secret Female Hormone, total testosterone over 30 nanograms per deciliter is what she's looking for. And then free testosterone, which is the unbound form, is over 7 to 10, depending on the lab. So you guys can check out my slide, write these numbers down, but find a doctor who knows what they're doing. Usually most of them that are smart will be brave and they will dose you until you have symptom resolution. Now, note, testosterone's a DEA license only hormone. It's the only hormone you need a DEA license to prescribe. So this is a controlled substance. So they're not going to hand it out mamsy-pamsy. Not every doctor's comfortable doing it. So if your doctor says, I'm not comfortable with that, they either don't have a DEA license, because not every doctor is required to carry one. We pay hundreds of dollars a year to have a DEA license so we can prescribe testosterone and opioids and controlled substances. So not every doctor does that. Not every doctor is comfortable with this. Not every doctor has practiced doing it. And not every doctor is as brave, right? They don't want to play with something they might think is dangerous. They've read it could be dangerous because testosterone's been vilified. I mean, so much so I'm afraid to use the word on Instagram because of censorship. And so it's a real deal. So the book is The Secret Female Hormone. Oh, I want to correct myself. Earlier in the presentation, I gave you the name of an article. I called it a book. It's in one of the first few slides. That was actually a really great article. This is the book I was talking about. This one is red. The cover is red, and it's called The Secret Female Hormone by Kathy Maupin, MD. It's a wonderful book. Everything I've listed, though, in this presentation is well worth checking out. Going back to the adrenals, remember the HPA axis. We got to support it. Your adrenal glands make your testosterone in your ladies, and in men, it's in your testes. So we need these adrenal glands on board. And men, when your testes start petering out in andropause, you need your adrenal glands on board. So there's a product I carry called Resilience, which is an adrenal tonic. It's got glandular adrenals and it's got adaptogenic herbs. It's a really phenomenal adrenal product, well priced, and you can find these products anywhere as well. All right, so some quick lifestyle, of course, because I think, me, those are the non-negotiables. I'm not a huge fan of supplements first at all, or hormones first. I'm a huge fan of lifestyle. And without lifestyle in place, nothing works. You can take all the supplements and shots and creams and testosterones and all the things, and nothing will stick or take hold for very long. So number one, strength training, non-negotiable. You have to build muscle mass. This is how we naturally hone and stoke our own testosterone. Number two, sleep, completely non-negotiable. You got to get your sleep in order. Work with somebody if it's not going well. Number three, blood sugar dysregulation. I beat the drum on metabolic health. That's like the whole premise of my platform. So go back and listen to all my episodes, grab my metabolic revamp toolkit, get your blood sugar and your metabolic health in order. Stat, that's critical. Without your metabolic health, you will never have healthy testosterone levels, period. But without healthy testosterone levels, it can be challenging to get your metabolic health in order because, again, it's chicken and egg situation. So do what you need to do. Adequate healthy protein and fats. I'm a big fan of red meat in particular. Any of the ruminant animals, venison, which is deer, sheep, which is lamb, beef, which is cow, goat. If you eat goat, I've never eaten goat. My husband says it's good though. So I don't know. But any animal that has more than one stomach is going to give you really healthy, digestible, absorbable forms of minerals and nutrients and vitamins. Decrease your cardio. Listen to a couple episodes back. Decrease your cardio. Cardio is not testosterone's friend. In fact, I should have put the study in here. I just came across a study showing that there was a 40% decrease in men's testosterone levels who were chronic runners. So you marathon runners out there, you long distance cyclists, you are bombing out your testosterone levels, men and women. Decrease your adipose, especially the dreaded gut. I talked already about how the aromatase enzyme is secreted by the belly fat, but fat on your body is going to mess up your hormones, period. And it's going to lead to metabolic dysfunction. And that is the end of your hormones. Metabolic dysfunction is, you cannot have balanced hormonal health without adequate muscle and low body fat. This is not a judgment. This has nothing to do with fat phobia or any of the above. It's just physiology. It's how our bodies work. Excess adipose is going to shoot you in the foot in a lot of ways. And one of them is that it's going to bust your metabolic health. And I have yet to see somebody with excess adipose who has a healthy metabolism, and therefore you're never going to have good balanced hormonal milieu. Decrease your alcohol, especially IPA. IPA is straight up an estrogen tincture. Straight up. Hops induces estrogen. That's it. So IPAs in particular are estrogen tinctures. This is what's wrong with Portland. The whole city loves their IPAs. All the dudes there look like it. And if you want to go see the clinical picture of low testosterone, just go hang out in Portland. Sorry if that offends anyone. I grew up there. People were trying to battle it out on Instagram when I was talking about this the other day. And I'm like, yo, I grew up there. I've been alive. I've lived in Portland longer than some of the people arguing with me have been alive. And they're like, I live in Portland and I don't think that's true. And I'm like, I looked at your bio. You're low testosterone too. No disrespect. It's not a judgment. It just is what it is. If you want healthy testosterone levels, well, let's put it this way. If you want good health overall, if you're a man and even a woman, you're going to want adequate testosterone levels. And so we don't want this low T picture chronically. It's not a good look. And down the line, it's going to lead to poor aging. And so that's what I'm most interested in. I know we don't think about that in our 20s and 30s and maybe even 40s, but man, we really want to be setting ourselves up for aging well and aging healthfully when we're younger, when we have the opportunity to. So cut the alcohol down or out, but alcohol is not your friend if you're trying to get your testosterone levels in line, men or women. And then, of course, drugs, all kinds of drugs. And I don't just mean recreational drugs. I mean pharmaceutical drugs. Pharmaceutical drugs can wreak all kinds of havoc on your hormones. And then stress. Stress is, I know this is easier said than done. I know all of these are easier said than done. When you hear me speak with conviction, I'm not trying to shame anybody or dog anyone. I know we're doing the best we can do. I'm trying to bring awareness, and I'm trying to let you know this in a way that it's the come to Jesus talk. I'm done tiptoeing around these subjects lightly. This is not cool what's happening. Humans are in trouble. And I feel really strongly that I was put on this planet to help. And I can't help if everyone keeps arguing with me and getting their feelings hurt. So figure out a way to fit these things into your lifestyle as best you can and really focus on stress reduction. It might require a change of jobs. It might require a change of relationships. It might require you move. For all of you, if you guys don't pay attention, we need to be strong and healthy. And this is how we do it. This slide right here. There's foods that raise testosterone. I mentioned a few. So protein, period. Animal protein. I should change the slide to animal protein, not just protein. Eggs, eat the yolk, you guys. The yolk is the best part. Beef is my favorite testosterone boosting food. Fatty fish. So that's where, I mentioned fish oil, but if you want to eat fatty fish, all the better. Oysters are huge. Onions are helpful. Pomegranates are actually quite helpful too. And ladies, pomegranates are helpful for estrogen. So pomegranates are a really wonderful, magical food. When in doubt, just remember this: eat meat, lift, sleep, sun, and sex. We have to have intimacy to have our testosterone levels adequate. For this is really important for men, but it is also important for women. So finding a way, maybe we're solo, whatever it takes, we got to use it or lose it. It helps your hormones, I promise. And then review your prescriptions. This is something no one's talking about, and I'm going to do a whole episode about this someday, but I shouldn't say what are they taking. This is kind of a confusing slide. What are you guys taking? Ladies, what are you ladies taking statins, opioids, steroids, over-the-counter, the oral contraceptive pill, all of these things are going to impact your hormones, of course. And then what are these ladies, you ladies, what are your male sexual partners taking? Because their semen impacts you and it impacts your health. That's the one I need to do a whole podcast on. And then above all, lift weights. So reduce inflammation. This is really critical. And the last 2 slides, I showed you how to do that. Reduce your stress and consider hormonal replacement, especially if you're in pain. Really important to look at your testosterone levels. And with that, I will bid you adieu. Thanks for listening to the Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guild. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtina.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtina.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.